Ayo, ih alay banget sumpah itunya. Jelek banget, Bu.
So do we start now?
Yes, we should start now.
Okay, thank you. So guys, are you ready?
Yes, we are ready.
Okay, thank you. So I'm audible to all of you? Please put a comment box.
Yes, you are audible. Please near
Okay,
your mic.
okay, thank you.
Excuse me, moderator. I think your microphone is still muted. Yes, we cannot hear you from the beginning. Maybe you can repeat and proceed. Thank you.
Okay, thank you. So I think I should start now. I'm audible to all of you or not?
It's clear
Yes.
now.
Okay,
Yes,
thank you.
start now.
It again. Yes, now
All
you
but not
can.
me.
Okay. Yes, you can hear you now.
Okay, thank you. I would like to start this session with the name of Allah, who is the most beneficent and the most merciful. Assalamu alaikum, everyone. I welcome you and congratulate you all of you for attending this session. I'm here at Muhammad Anas Nawaz. I'm representing IVSA Pakistan at this platform. For the first of all, before moving ahead, I would like to thanks to IVSA Global who provided this opportunity during this symposium. Our original representative, Andy Fermansa, our chief organizer of the symposium, IVSA Nepal, and all the co-organizers of the symposium who put their effort for the success of the symposium. I'm very thankful to all of you. Thank you very much. For the viewers joining us for the first time, this online symposium is organized by IVSA members that stand for International Veterinary Student Association. It is consists of 16 presentations on various aspects of zoonosis and public health. It will be continued for consecutive 4 days, and each day we have 2 sessions, and each session we have 2 presentations. And this is our 3rd day, and we are heading toward our 11th presentation. So before the introduction of our renowned speaker, I would like to put forward some instruction for you people. Please listen carefully. First of all, please keep your microphone mute and turn off your camera. Please maintain the decorum of the symposium. Please maintain the decorum of this session. I'm very thankful to you for this. Second, if you have any question about our speaker presentation, please put your question at the chat box or a YouTube live stream, which will be answered at the end of the session by our speaker. And the last one, but not the least one, at the end of this session, you will receive a unique code, which is important to note down for getting your certificate. So now, without any delay, I would like to welcome to our speaker, Dr. Nasikbal. Here, Dr. Nasikbal has passed his Doctor of Veterinary Medicine in 2017 from the Islamia University of Bahawalpur, Pakistan. And after that, he completed his master's in the Department of Clinical Medicine and Surgery from the University of Veterinary and Animal Sciences, Lahore. Now, he has been granted with the Turkey Burslahari Scholarship for his Doctor of Philosophy. He remained the teaching assistant at the Department of Clinical Medicine and Surgery at the University of Veterinary and Animal Sciences, Lahore. And he has published 7 international and many national research articles in different journals. And now many of them are in the process. He remained the leading member in different societies which are working for the civil veterinary and other societies and social societies. He is the active member of National Organization of Pakistan. Now, it's our honor. He is working as a Director General for IVSA Pakistan. So, without any delay, I welcome you, Dr. Nasir. I'm very thankful to you. Please come, and now this floor is yours. Please come ahead. Dr. Nasir.
Well, thank you so much.
Thank you so much. So please come. Dr. Nasir, are you listening?
Yes. I'm just waiting for the sharing of the screen.
Okay, thank you. Welcome you, sir.
Okay. Just a second. Shall we start now?
Yes, sir. Sure.
Okay. Hello to everyone. Today, I would like to introduce myself. This time, I am Dr. Nasir. Yes. My topic is epidemiological investigation.
Sir, please share your screen.
Yes. So
Sir,
before
please share your screen.
What is epidemiology?
Dr. Nasir. Dr. Nasir. Dr. Nasir, please share your screen. Still not.
Can't you share now? Yes. I'm sharing
Still not.
again.
Yes, yeah.
Just a second.
Okay, sir, no worries. Sorry, guys, for the delay.
Is it now?
Yeah, sure. Still not. Yes, sir. Yes, sir. Yes, sir. It's shared. Now you can continue. Thank you.
This is a public. So we must look at epidemiology. With just one thing, and that is, it is somehow a dry subject. But going ahead, I have put a few pictures in it. So, I want to know that which just carry out and two sign the epidemiological investigation. First of all, determine what is the cause of an outbreak. Just like as in the current scenario, what we are suffering is an outbreak that has been determined from the past few months. And now we are implementing different control measures, like we are using hand sanitizers, we are using masks, we are using gloves, we are not shaking hands. These are few preventive and control measures to implement to avoid additional illness. Okay, so now the second part of the topic is the zoonotic diseases. So basically, what are the zoonotic diseases? All those diseases which can spread between animals and humans are termed to be zoonotic diseases. So before going ahead, I would like to describe a few points about the zoonotic diseases from the history that were pandemic, epidemic, endemic, or exotic as well. Okay, first of all, the first ever zoonotic pandemic was the Black Death. In 1347, in 14th century, the Black Death came over there, and what we had faced that was, uh, we can say a drastic one ever. About approximately 750 million people had been died, and the Black Death was caused by a bacterium known as Yersinia. Later on in the 16th century, in 1564 or something like that, a came over there from the virus named as Flaviviridi, from the family Flaviviridi, and the virus Flavivirus came over there and caused the severe economic loss. Though these were not that much as symptoms, these were the somehow. Okay, before moving ahead, I would like to tell you the first one was the bacterium, and the second pandemic was, and later on it became again a bacterium. In 1850s, brucellosis came over. What was brucella? Brucella is again a bacterium.
Sir,
And the
sir, your voice is breaking intermittently and there is background noise as well.
So please clear your voice. It's not so clear. Dr. Nasir, are you listening?
Hello.
Dr. Nasir, are you listening? Sir, your voice is not so clear. Sorry, guys.
Yes.
Sir, so please start. Sir, you can start now. Please try again. No, sir, it's
Okay.
not so clear now. Still. Dr. Nasir, it's not so
Sorry?
clear still. Yes. Sir, it's not so
What
clear
should I do now?
still. So please try now.
Okay. In 1850s, a bacterium known as, that is a strain of that caused economic loss in the past year. In 19th century came over there, and it was also termed as zoonotic disease that came from human to animal and animal to human as well. In 1885, there came two bacterium again, the gram-negative bacterium that affected the gastrointestinal tract, that was E. coli and the Salmonella. After that, in the early 20th century, a protest to reduce the parasite came over there to drastic effects over the world. And in 1918, just after a few years, a severe pandemic that was named as Spanish flu came over there and most brought from the United Kingdom into Europe was affected from the Spanish flu, and record deaths were recorded at that moment. And in 1975, a disease came that was named as Lyme disease, which, that was caused by the Borrelia. Organ. Later on in 1976, Ebola virus
Dr.
came over
Nasir,
there that was
Dr. Nasir,
yes, yes.
yes. Sir, please, your voice is not so clear. Can you check it again?
Hello.
Yes, sir.
Someone.
应该是，他是哪儿的人？
Dr. Nasir, you can start now.
I can start now, but there are that are open, and I can give email listener.
Sorry for that interruption. We can mute all.
Yes, yes, please. Okay, in 19 it was just because of the and affecting the world. Okay, in 1993, in a viral disease was there that was epidemiological, that was also came under the category of diseases and was 7 onwards till date. What we can see, viral diseases, viral viruses that affect human beings who answer on that track or I the Mr. System. Again, I would like this 1999 the Zika virus was there, it was causing different aches like head. In three,
Dr. Nasir, your voice is again interrupted. Dr. Nasir? Dr. Nasir. Sir, please check your internet connection again.
To Anas, I think
Yes.
you can suggest him to just turn off the video and so that the internet connection will be focused on his sound.
Okay, try again.
And maybe after this you can share the screen while the presenter just explain the explanation.
Yeah, I understand. Thank you. Understand.
Okay. I'm sorry to all participants that disrupted about this. We will try a way out soon. Thank you.
Sorry for that interruption. Thank you. Dr. Nasir, are you here?
Hello.
Yeah. Yes, sir.
I'm continuously
Please take.
getting irritation from the few females, and they are talking in English with each other.
Actually, sir, your voice is not so clear that just seeing us. Sir, please turn off your video. Just talk at voice.
Okay, I'm.
Sorry for that
I
interruption.
cannot even. Okay. Allow me to share.
So again, your voice is not so good.
Voice.
Sir, please.
Hello.
Yes, sir.
Okay.
Please turn your camera off.
Hello.
Yeah, sir. Please try again. Yes. I listen you.
Sir, can you see presentation on screen? I have opened it.
I'm getting on this.
Okay, I will continue this screen. You will read from here.
Okay.
Okay?
Please.
Okay.
Yes. Please.
Dr. Nasir, please continue. Dr. Nasir.
किधर गायब हो गए हैं? आवाज नहीं आ रही आपकी।
Sorry guys for that issues. I think it's an internet issue. Otherwise, doctor is ready. Dr. Nasir, are you listening me? Dr. Nasir.
Hello.
Yes, Doctor.
Okay, I will switch off my video. Dr. Hamza will presentation.
Sir, your video again open. Please switch off. Okay, sir, please try again.
Now you can hear me?
Okay, sir.
Okay.
Yes, yes.
Before
So please try.
proceeding further, we should first know what is an outbreak investigation. If you want to understand the concept of zoonotic disease outbreak investigation epidemiologically, we must know what is an outbreak investigation. Okay. So if we are getting or expecting something, that will be an ideal number of cases. Let's suppose if we consider that there should be 15 number of cases in 1 month, and there came in a specific area. For example, in Pakistan, we consider that there will be 15 to 20 cases in 1 month, but there came almost 1500 2000 cases. Then what we can say, the more than normal expected cases in a given population and a given time, that will be termed as an outbreak. Next slide, please. Yes, outbreak detection. So how we can detect it, is it an outbreak or not? There are several ways. First of all, I would like to tell the surveillance. Surveillance is the control. How we can confirm or detect the outbreak. So first of all, what I can say is the active surveillance. Active surveillance means if a veterinarian is there, if a abattoir worker is there, if a assistant is there, he is working over there, and he get the information about a disease or clinical signs and symptoms. It is called as active surveillance. If all the details come to someone in a bunch, it will be called as a passive surveillance. And if you consider what is the syndromic surveillance, in syndromic surveillance, there will be an expected data came to you at a given period of time in a given circumstances, and you will expect if Pakistan is having this disease, God forbid, so in near future, Afghanistan or India will be in term of affection in the near future, or in the near month or near age or XYZ, whatever it can. Yes, outbreak can be detected either by social media and different terms as well. Okay, so what are the steps for outbreak investigation? First of all, I would like to tell you in details. First of all, prepare for the field work. We have to do some study over there. It can be case study, case control study, cohort study, or any other type of study as well. And then we will establish the existence of an outbreak. Just like that, right now we are establishing that the coronavirus is there. And then will construct a work case definition. What is a work case definition? Work case definition means if a person having this symptom, then we will call this a dash disease. Just like as I can quote an example, if a person having flu, cough, sneeze, and respiratory distress, we can say this is a COVID-19 condition. So this is a working case definition. So after that, we will find different cases systematically in different areas, and we will record information from different areas. And then we will perform a descriptive epidemiology. What does it mean? It means describe the distribution of diseases in different areas. Like COVID-19 is present in this, and this area. And after that, we will develop a hypothesis. Hypothesis means we have an assumption or right out there, and after the assumption that we can consider that these are the clinical few times, and we will consider that it can transfer from handshaking. And even and after the investigation in the near future, we can reconsider, refine, or re-evaluate the hypothesis either by handshaking, is it transferring to the other patient, other human being, or not. So we will compare it with the laboratory or the environmental study just for the confirmatory diagnosis. Now, what we can go with the PCR, RT-PCR, real-time PCR of the COVID, and then we will go for the implementation of the control and preventive measure, as we had diagnosed the confirmed the disease is COVID-19. So we had implemented a different controls and preventive measures, just like as right now we are not shaking our hands, we are using hand sanitizer, we are using gloves, we are using masks. These are the control and preventive measures that we had implemented. And after that, initiate or maintain surveillance. We have to maintain the control. We have smart lockdowns or specific lockdowns in specific areas, and then we will communicate finding either by social media, WhatsApp, Instagram, and other media as well. Okay, later on, now what is the outbreak investigation systemic steps? First of all, what we had did, we had confirmed the case, we described it to the people, and we will determine the cause, that it is caused by coronavirus from the handshaking and from coughing, sneezing, and then what we will do, we will control the disease. We will avoid handshaking. We will, as you all know, what we will do right now. Okay. Now, how you will confirm an outbreak? As we discussed in previous slide, the confirmatory diagnosis will be on two basis, either by clinical signs or lab test. But the confirmatory diagnosis always work with the lab test. You must focus on this. Next, please. Yes, we can describe outbreak spread cluster as well. Like we have a different mapping tool like geographic information system, GIS, we can say that, and the different persons who can be affected. We can right now tell who is at risk. Either a male is at risk or a female, means about the sex. We can tell about the old age are more prone to it, or a younger one can prone to it. If we discuss about the occupation, either businessman is prone to it, either an abattoir worker is prone to it, either a veterinarian or a human doctor. We will go for it. And same is go up for the ethnicity. Thank you. Next, please. Okay. Determine the cause. What will be the cause for this? Like, what is likely to be if we are not washing our hands and we are getting gastrointestinal tract infection? Either it can be cholera or salmonella. If we are using contaminated water, it will be cholera, and if we are using eggs and meat, it will be salmonella. We are getting hypothesis. Then we will go for the testing, for the confirmation, and the different studies just to evaluate the cause and to determine the hypothesis, either it is true or not. Then we will reconsider it, reconcile it, and refine it for the confirmation. Next, please. Okay, now we got the confirmation of a disease. I am just focusing on the topic COVID-19 because we all are much aware on the COVID as compared to the other diseases. Yes, we are also focusing on rabies. I will give in near future the example of the rabies as well. Okay, now can be implement. These are few control measures I am quoting in front of you, like behavioral. If there we consider about any parasitic disease, like it from the in mosquito. So what we will use mosquito repellents. Okay, vaccination is there for the measles vaccine. We are using this medication to avoid ticks. We use ivermectin in injectable forms or in per-oral form. Albendazole and different medications are there to avoid worms. Environmental measures. Right now COVID is there, we are using different spraying different antiseptics, and we use insecticides to avoid different insects, and to control infection we use different protective measures, like we use gloves, hands, and we also educate people just for the case of surveillance to avoid any improper uh, transfer of a disease from just because of lack of knowledge. Yes, please. Yeah. So, yes. Now that's the main and most important form of the communication. So how we can confirm and now we had confirmed. Sorry. Now we had confirmed the outbreak, and now how will you communicate? You will communicate either internally or externally. Internally, we have media, social media, and the multimedia that we can use design different sessions just like as we are using right now, or we have different research journals we can use. These are a few internal, accurate, timely distributing communications. If we want to use external, we use different NGOs and we will try them and trial them just to focus on these points, and they will go for it to ensure that the proper information is disseminated to the public. uh, what it will do, it will definitely reduce the anxiety among the people, that will change their behaviors, that will be towards surveillance, that will avoid confusion among them, and basically it will avoid misinformation regarding any disease, any sign, any symptom. Yes, please. So this was all about the epidemiological investigation. I guess you may got 5 to 10, at least 5 to 10% about the epidemiological investigation, how we can investigate a disease. Okay, now go up for the zoonotic diseases. So first of all, the basic zoonotic disease what we are facing is brucellosis. Brucellosis is also known as undulant fever or Mediterranean fever or Malta fever or Banks disease. It is a contagious disease of livestock with significant economic impact that will be described in the near future, and it is highly infectious to humans as well. Okay, next slide, please. It is called as undulant fever because of intermittent fever in daytime and the evening and the night, as we all know, being veterinarians. Okay, brucellosis in animals. Brucellosis in animals. First of all, I would like to tell you these are there are different strains of Brucella, but right now I am telling you the main ones that has been included in the OIA list. The first one in the cattle, it is Brucella abortus. In the sheep and goat, the Brucella melitensis, and in swine, it's Brucella suis. The one that is affecting more in humans as compared to the other is the Brucella melitensis. Ah, well, uh, what are the confirmatory diagnosis and recommended screening tests? If you are working on a local circumstances, you got the clinical signs just like as abortion and the otitis and swelling of the joints in the animals. Then what you will do, you can do either a milk ring test for the diagnosis. RBPT is a Rose Bengal precipitate test, one of the most common and most famous tests. Either SAT and the ELISA you can perform. But for the confirmation, either you will go for the isolation and identification of the Brucella species from the PCR or by a detailed confirmatory detailed test. Okay, how you can control and prevent the brucella. First of all, if you got serological test, it's good. Like milk ring test, it is perfect. And in Pakistan, I know there is a we use Bovishort brucella, a vaccine for the brucellosis. And what we can do for this, the main thing, and to control the brucellosis is control the infection in animal and consumption of pasteurized milk. Everyone must use pasteurized milk or boiled milk in spite of using raw milk because it may contain brucella in it. Thank you. Next, please. Okay, the next and the most one is the salmonellosis. The term salmonellosis covers a complex group of foodborne infections affecting both man and animals. I would like to tell either you all know or not one thing, that every living being in the world is suffering from salmonellosis. Either it is a plant, either it is an animal, either it is spices. Everything is suffering from salmonellosis from the bacterial point of view, and from the viral point of view, they are suffering from the influenza. The term food poisoning is commonly applied to the salmonellosis because about 60 to 80% of total cases of food poisoning came under the salmonella, because the sole causative agent that will be in near future proven, that will be salmonella. Next slide, please. Okay, as I told you earlier, it represents 60 to 80% of all reported cases of foodborne diseases. While the incidence of typhoid fever has declined, the incidence of other salmonella infection has increased in the developed countries. So basically, there are three types of salmonella that affects. Next, please. That can affect the human beings, and these this will be near future. Okay, salmonella is classified in three groups. Either it can infect or affect only human, or it can affect a specific host species, or it can affect both man and animal. So if we are getting that animal is not infected, but from animal it is transferring to the human, that is Salmonella typhi, Salmonella paratyphi, E and C. Okay, if it is a host species, it is Salmonella dublin. Previous slide, please. Or Salmonella cholerae. And if we are confirming that the infection is in both man and animal, it can be Salmonella typhimurium and Salmonella enteritis. Okay, I would like to tell you one thing, that in Pakistan, what I have seen, almost every company which is working with the ready to eat and ready to eat and ready to cook meat, they all are focusing on Salmonella, Salmonella typhi, Salmonella paratyphi, Salmonella typhimurium. They all are working on it. Okay, so how we can do prevention and control in it? We can do immunization of farm animals against salmonellosis. It is much more important than anything else, to avoid the severe economical loss and to enhance the productivity of the animals. We can use the hygiene animal feed, because salmonella came in food, in the fodder, in the food, in the concentrate of the animal, and ensure a sanitary environment for the animal, because it has been reported from the water as well. Next slide, please. Okay, next game is the plague. I would like to few points of the plague. It was an old disease, but it was caused by a bacterium that was called as Yersinia pestis, and it came many form in exotic, episodic, sporadic, and endemic as well. Next slide, please. Okay, human plague can be transferred to the different ways. Because it is not common in Pakistan, but as we are covering around the world, we can discuss it. Commensal rats. It can be transferred from the commensal rats that have the plague to the rat fleas, and rat fleas to human. Again, from the it can be either from the wild rodents to their contact with the human. Wild rodents. Third one is the wild rodent to the pre-domesticated animals, and again to the human. And so the next one is man to the human fly that having human plague, and then to the man. And the next one is the direct man-to-man contact. The bubonic plague. I had highlighted it in yellow because I have seen a few cases right now, or have heard about the few cases that are coming again, bubonic plague. So we must use insecticide and pesticide to avoid such a type of infection in the near future. Bubonic plague came over again in China. I have heard about that. I'm not sure, but I have confirmed it in a few things. Okay, again, pneumonic plague and bubonic related to the the rat will bite over the extremities of the body, like on the nails, on the tail, on the ear tips, on the fingers, extremities. Okay, the pneumonic will affect the respiratory tract, and the septicemic will be again the systemic, and it is rare one. There will be a bubonic either or pneumonic, and these two had affect human in the past. Please. Okay, prevention and control. How we can prevent or control the disease? If we can control the number of cases, to avoid and to have quarantines, and to control the fleas, we use different insecticides and pesticide for this, and to control the rodents, so anti-rodents can be used, and anti-rodent sprays and the baits can be used to avoid the rodents. Next, please. This is the most famous and the hot favorite disease of every veterinarian, that is the rabies. Rabies is a zoonotic disease, and almost in every part of the world rabies is present, and about 60,000 people die just because of the rabies each year, almost in the Asia and Africa. Rabies virus infect domesticated and wild animal and is spread to people through close contact from the animal saliva via bite and scratches. Next, please. Okay, what are the main basic things? I must tell you, as you all know, but I have to clear one thing, that it cannot transfer from the respiratory tract or the muscles. It always, or cardiovascular system or the circulatory system. It always travels from the nervous system. So, what we have to say, we can say that if the part where the animal has bite over the human body is more important than the effect. And the next thing is the PEP, post exposure prophylaxis. Everyone must be immune, every veterinarian must be immune to it, every veterinarian must be vaccinated. It can be transferred from bat, fox, cat and skunks, but we all know the dog is most common here, and dog have the virus, Lissa virus, in its saliva, fever, agitation, painful sperm, and the death within a week without a vaccine. So I must insist, and today the learning point of view is from the rabies is that everyone must have vaccine, and if someone is infected or a dog bite, there must be PEP, post exposure prophylaxis. Next, please. Okay, rabies is a vaccine. Okay, we have nothing to do with this. Everyone know about that. Yes, please. Next, please. As we have shortage of time. Okay, vaccination in human is recommended for anyone at continual, frequent, or increased rate of exposure of rabies, either as a result of their residence or occupation, and every traveler with extensive outdoor exposure and children living or visiting rural high-risk areas. Everyone must be vaccinated from the anti-rabies vaccine. Next, please. We have seen a lot of cases. Yeah, it is something funny about that, but how you can identify a zombie? Either it is a zombie or rabbit. So as we all know, it will be always having hypersalivation, just like as the cursor is there, hypersalivation, animal having cooling saliva. It will be in a restlessness and an anxiety and having a muscular spasm. The jaw will be open because there will be muscle spasm and the convulsion will be there, and it will having hydrophobia and hypersalivation. But in zombies, what we can see, they have higher cognitive ability, craving for flesh, and different missing body parts and bad breath and hopping gait. But unlike these are not in the rabies. This was just for the fun, just to entertain all of you. Okay, so as I told you earlier, the post-exposure prophylaxis (PEP) is most important, and I have seen in Pakistan and learned about different cases that there are a lot of human deaths reported just because of lack of or absence of PEP. Thank you. Next, please. Yes, MERS, Middle East Respiratory Syndrome. It is a viral respiratory illness that has been reported in 2012 in Saudi Arabia, and also came next, please. The positive agent is the coronavirus. uh, it was found in the camels, basically in the Qatar, in Egypt, in the Saudi. Basically, that's why it is called as Middle East Respiratory Syndrome. So in Qatar, Egypt, Saudi Arabia, and United Arab Emirates, as there are a lot of camels there, so just because of the reason we are getting the COVID there, and we have tested positive for antibodies of MERS COVID. Either they have got the disease previously, they have any animal. So what we can do, what we can do right now, we have a post prophylactic PEP, post exposure prophylaxis. In it, what we have to clean the wound that has been caused by the bite. From the best and ideal one is by using the carbolic acid, from carbolic acid or separate. the ethanol is there. Okay, we can use, or we can wash. After washing, we can use sunlight exposure to just for the to avoid the bacterial transfer. After that, we can also use different anti-rabies vaccine from the human as well as, and because the vaccine is same, the post-exposure prophylaxis duration is, there are two types, either on day 1, then day 7, and day 21. That is the one. The second one is the day 1, day 7, day 21, day 28. And some few people also use this day 1, day 7, day 14, 28. And then it will be repeated after 1 year at the same exact date of the day 1, and after 3 years, exact date of the day 1. Thank you.
Okay. My next question is, what is the meaning of emerging zoonosis? Factor that explain the emerging of zoonosis, zoonotic disease.
Well, those diseases which have been got outbreak within no time, and we don't even know what is the cause and how the animals and humans are dying, and we have got a close connection between the humans and the animals, that will be termed as emerging zoonotic diseases. There are
Okay.
different factors, as we all know that the epidemiology is there. Epidemiology have three factors: the humans, the animals, and the environment. Environment have vector, the food, because for the food purpose use lot of animals in the farms, and if one animal is infected, then the all will be infected and the disease will be transferred from one to all. And if it will be zoonotic, it will be definitely working the it will be affecting the humans, the veterinarians, the workers, and all around the society as well.
Okay. My next question is, what is the possibility of occurrence of smallpox in the new generation, given the fact that they are not vaccinated against it?
Sorry. Can you
What
repeat
is
it,
the
please?
Okay, thank you. What is the possibility of occurrence of smallpox in the new generation, given the fact that they are not vaccinated against it?
Well, there are few post exposures or there, but I haven't seen that people once got the smallpox and they have been in. But what we can do, we can say the autoimmune vaccination or autoimmune system. What we can do in it, if a person have been exposed from the smallpox, we got the serum from them. We got the serum from them, and we have introduced it into the new generation, in the new people, just in the form of, if we can say, the vaccine, so that they will be overcome, or they will cope up with the smallpox in the near future. But it can be affected, and it may not,
Okay.
because we haven't sure about the strain of that. Yes, please. Next.
Okay. Last question is, how much time required to prepare a vaccine nowadays?
Sorry, how much time
How
is
much
required for?
to prepare a vaccine nowadays?
We cannot say exactly about the time period for a vaccine to be prepared, because there are a lot of circumstances which have to be described. First of all, we all must know the strain. Then it depends upon the incubation period of the virus, so that we can cope up with within the incubation period of the virus. And we have it. Well, it is a lot, but it is a long science, so we cannot describe it how it can work and how it is timely possible. So we cannot describe it. Sorry.
Okay. Okay. Thank you so much, Dr. Nasir. We are very thankful to you. Okay.
Thank you so much. Thank you so much. Thank
For
you.
all the participants, sorry, we are very apologize for the inconvenience that happened today. We are sorry for that. Okay. So, guys, please stay there. Now, the next presentation is start. IVSA Nepal is continue for this session. So, I invite Pratik or IVSA Nepal. So, Pratik, are you here?
Yes, Anas, am I audible?
Yeah, you are.
Okay.
Thank you, Audio. You can continue now.
Okay, thank you, IVSA Pakistan, for your nice presentation, and I would like to thank Dr. Nasi for his nice and very informative presentation. So hello and namaste everyone. A warm welcome to all the participants and to our esteemed speaker for today's session. From the organizing team and from me, all 13 MOs, we have been working tirelessly for organizing this online Asian Symposium. So this is me, Exchange Officer of IVSA Nepal, BVSC and AIRS, final year, and moderator for this session. I hope all the participants are now well acquainted with the guidelines for this online symposium of muting the mic and disabling their video. For the viewers joining us for the first time, the online symposium is organized by IVSA member that stands for International Veterinary Students Association from all over Asia, which consists of 16 lectures on various aspects of public health and zoonosis by renowned speakers from different parts of Asia, which will be held over a duration of 4 days. So we are in the third day, evening session of the symposium. Before introducing our esteemed speaker, I would like to put forth a few instructions for everyone. So participants can ask their doubts and queries in the chat box, which will be answered by the speaker at the end of the presentation, keeping the time limit in mind. So as you all have well acquainted with the guidelines, I would like to welcome Dr. Ajit Kumar Karna, which we are very fortunate to have here in our symposium. So Dr. Karna is a veterinarian, public health scientist, and microbiologist, currently working as an associate professor in veterinary public health and epidemiology in HICAST, PU, Nepal. He has worked in New Mexico State University, USA, as a postdoctoral research scientist and an adjunct professor of epidemiology, USA. Dr. Karna has obtained his veterinary medical degree from Tribhuvan University Institute of Agriculture and Animal Science, Chitwan, in 2009. After working as a veterinary clinician for a few years, he joined the University of New South Wales, Australia, for Master in Public Health and International Public Health. After completing his master program in Australia, he moved to Colorado State University, the USA, where he obtained a PhD in microbiology, virology, and epidemiology, to be specific, in 2017. Furthermore, he has then worked as a postdoctoral research scientist in the Department of Biology and adjunct professor in the Department of Public Health Sciences at New Mexico State University. Dr. Karna is member of the American Society of Tropical Medicine Hygiene, American Society of Microbiology, Nepal Veterinary Association, and a lifetime member of Nepal Veterinary Council. He was the recipient of Australian Government Endeavour of 2011, Australian Government Development Scholarship 2011, and Livestock Climate Change Collaborative Support Program 2012. He has authored and co-authored a number of peer-reviewed research papers on infectious disease. His research interest is on infectious disease in general, particularly zoonotic disease. So, Dr. Karna, are you able to turn on your video?
Yes, Pratik, thanks. I just turned on my video. Can you hear me and can you see me?
Yes. Okay, yeah, we can see you and hear you too.
All right, so shall I go ahead or am I still waiting?
No, you can go ahead, sir. Sure. Can you share your screen?
Okay. Can you see the screen now?
Yes, sir. Sure. We can share. We can see the screen. Okay, sir. The stage and time is yours. I can continue. Thank you.
All right. Okay, thanks Pratik and thanks IVSA and globally and IVSA Nepal for letting me speak on recent diagnostic tools and its application in zoonotic diseases and it's very relevant this time of the year or in a moment where there is a pandemic of COVID-19. Okay. So you're very familiar with the zoonotic diseases, and zoonotic diseases are those diseases which you know already that it's transferred from the other animals. I consider other animals other than the humans. Humans are also animals, but I'm considering other animals as an animals which does not represent like humans. So any disease or infection that is naturally transmissible from the vertebrate animals to humans are zoonotic diseases. And as you are aware that the 60% of the infectious diseases that are existing in human cycle are zoonotic nature. And at least 75% of those emerging infectious diseases that includes Ebola, HIV, influenza, including the SARS coronavirus 2, have an animal origin. And 5 of the new cases that occur every year in humans are of zoonotic nature, and 3 of those are of animal origin. And 80% of those agents which are zoonotic nature are considered as a potential bioterrorist agent, and they are being tested around the world for the nature that they can pose to the human and environmental health. And animals plays an essential role in maintaining zoonotic infections in nature. And you can see that take an example of rabies, for example, and in rural Southeast Asia, dogs are playing a crucial role in maintaining the rabies transmission in the human cycle. And COVID-19 has emphasized how important it is to diagnose and control diseases emerging at an interface of humans and other animals. That's why we always try to find the techniques and tools that can be used in early detection and early warning and control as soon as possible to prevent the catastrophes that is happening right now around the world due to COVID-19. And the challenges that we are looking at right now in the disease control globally is I have categorized those on 3 different bases: diagnostics, epidemiology, prevention. The diagnostic of choice that you are employing for any disease detection, and you are considering that for the time. I will talk later on like why time is so important. And money, not very many labs in the countries like Nepal or India or Pakistan or Bangladesh or in many other countries in Southeast Asia have enough money to support the laboratory exercises. And for COVID-19, the laboratory facilities is not so easy. You need to have good laboratory facilities to prevent infection among yourself when you're working in the lab. And obviously that depends on the sample type, like what you are trying to test. And what is your sample of origin? What kind of sample are you obtaining? And in the case of emergencies, there are lots of samples that are being generated from the center of collections. And then in the lab, you have to process. And those diagnostics are based in facilities. So the patient has to travel to the hospitals or super specialized laboratory facilities to be tested for the infectious diseases. And the epidemiology of the disease definitely presents a challenge because some are asymptomatic and some are symptomatic. For example, in COVID-19, large majority of the cases are asymptomatic. That presents a challenge that people who are not symptomatic are not coming to the laboratory facilities. Latent carrier, longer incubation period, and when you don't know when the symptom is occurring, then you cannot find the incubation period, and those persons can be super spreader sometimes. And many of the emerging infectious diseases or of zoonotic nature does not have the vaccine or any other therapeutics that can cover to prevent from severity or fatality. And what diagnostic test to use is again depends on what kind of sample you have, what do you want to test, like target product and equipment, or what you have in your lab. The whole blood, serum, saliva, urine, feces, and vectors such as mosquitoes, ticks, and others. And the surface sample, like if you are taking the sample from the doorknob or from the ventilators, for example, or others. There could be many sample that you can obtain and wanted to test, but then what you want to test, it depends on your research questions or your target question. For example, nucleic acid or RNA or DNA or proteins like prions, antibodies, and antigens. Like that's your product, a target product. And then when you try to manage your diagnostic facilities to test these kinds of target, then you have to go back and take the relevant samples, and then the relevant equipment is needed. Like for example, if you are trying to do the PCR test for the nucleic acid, then you have to do the PCR-based assays, like RT-PCR, conventional PCR, qPCR, real-time PCR, so many different kinds of PCRs there, ELISA and CLIA, and even like, you know, if your lab is BSL-3, sometimes the zoonotic agents are require BSL-3 facilities to be dealt, like, you know, pathogens of high special interest, like, you know, select agent in the US, that needs to be done in BSL-3 facilities, and you are growing the pathogens when you are doing the cell culture, and that is actually that is a choice we should have for the COVID-19, but in low and middle income countries and in many other different countries, we don't have a good cell culture system or the laboratory facilities to do cell culture. And next one is sequencer, like Oxford Nanopore, Next Gen sequencing, Illumina, and whatnot, and so many others that can be used. But that again depends on your sample target product. For example, in SARS coronavirus 2, I'm trying to show you what is the real scenario happening right now. Is that somebody is coming at the health center at getting their swab taken, and the flowchart here is showing different steps that are involved in extraction of nucleic acid from the swabs, and that is put in the real-time PCR machine, and it's taking 4+ hours per test. Or there are 2 or 3 people, or more than 2 or 3 people are required to do all the 96 samples, for example. And it requires BSL-2 plus laboratory facilities if you're doing the PCR. And the discomfort that it's causing to the humans, like for example, the nasopharyngeal, oropharyngeal swab sample collection is not so easy. I have tested myself, so I know how painful it is and how discomforting it is. So it is taking like 3 or 4 or 5 days, depending on when the sample was taken and when the sample was shipped to the laboratory, and when the samples were processed, and then the patient find out the result in like up to 5 days. That's currently happening in most parts of Asia. And so there's an alternative here, like that is loop-mediated isothermal amplification assay diagnostic. You can use different samples, for example, blood samples, swab samples, saliva sample, urine, feces, vectors, and whatnot. So many different samples, and that either you extract the RNA or DNA or total nucleic acid from those samples, and then the sample is either extracted or without extraction. There has been some studies without that extraction state. And then there is the BST DNA polymerase that has been added to the samples, and the LAMP mix, that is the loop-mediated isothermal amplification assay. And it's a very simple. It's put in a heat block, and there is a single temperature required. Like either you put it at 60 degrees Celsius, 65 or 72, depends upon your protocol, for 30 to 60 minutes, and gives a colorimetric readout, like for example, the positive could be green and negative does not yield any different results or different colors. So it's rapid, easy to read, and any samples can be processed. But it is under consideration right now in many parts of the world that if it can be used in a, like, you know, point of cares or point of entries or point of exit or in hospital settings, but its use as a diagnostic is still questionable, because the studies are going on right now and they are trying to put out different results. So when the information is going to be synthesized, then it is going to be validated, and then it can be used in the like human diagnostic settings. And for example, the lamp, which I'm really fascinated about, is the like, you know, when you have different genes target and you have different primer sets. For example, forward primers, like that's F3B3 inner primers, forward inner primers, backward inner primers, loop forward primers, loop backward primers. And this method, it depends on auto-cycling strand displacement DNA synthesis. I think you can go, I'm not going in detail here, but you can go back and read out the literature of LAMP method. And it's very easy, and it doesn't require an extensive laboratory facilities and sophisticated labs or trained manpower, like, you know, and it's easy to detect as well, like, you know, there's a difference in colors. So there are different steps that are involved, and you are putting all those primers within that single tube and throwing that out in the heat block, and then you are waiting for 60 minutes and looking for the result. And you can design your own primers using the Primer Explorer platform. And what we all like to hear is the diagnostic test assessment, that is sensitivity and specificity agreement, when we are trying to consider an alternative diagnostic tool in the case of emergency, or in the case like when we try to compare the results. So I don't have to go this chart, because most of you already know when you are trying to exercise your results, comparing the gold standard, and there is a true positive, false positive, negative, true negative, false negative, and then you are comparing how much percentage of the gold standard positive is other diagnostic text positive, and the detection rate by your diagnostic tool that can be precisely identified by the gold standard as well. So you are estimating sensitivity, specificity, agreement, and detection rate by your diagnostic test. And then what diagnostic test to use? I have already told you there are different methods of tests that you can use, but it all depends on what facilities you have. You cannot jump onto doing the cell culture, although it is like very good way of detecting the pathogen. You cannot jump onto it because it involves a lot of different regulatory procedures, and it involves a lot of different safety precautions in your lab. But it tells you if you find the pathogen, because you are growing the pathogen in cell culture, tells you if the pathogen is viable or not. If it is not viable, it's not growing, and it does not kill the cells. That you are putting on in a plate, like 24 well plates or 6 well plates. And if the person or other animals will be able to transmit the pathogen or not, it will tell you that. Because if it's the viable virus or pathogen, other like bacteria, you will be able to tell that the samples that is being obtained from the human or other animals could be transmitted to other in the proximity. And the molecular approaches, for example, the polymer PCR, the polymer chain reaction that tests for viral nucleic acid in the body. And due to the sort of the virus culture in many of the settings in Asia, we are depending on PCR test as a gold standard for COVID-19, for example. And the serological approaches, you can use ELISA about this, about testing the different pathogens in the community. And it's a very good way of measuring the burden of the disease in the community. And it tells you if you are exposed to the agent or not. It does not tell you you are infectious or not. It only tells you if you are exposed to the agent or not. If you find the antibodies specific to that agent. And again, it depends on the facilities and regulation in your lab or in your country. And I'm really overly thinking about like rapid diagnostic test. Someone says a rapid screening test. Some like to say a rapid antibody test. So whatever it is, we have to use it cautiously, and it cannot be used as a diagnostic method. Rapid diagnosis test kits claim to test the immunoglobulin M, or acute phase antibody, and immunoglobulin G, that is IgG, appearing later in the course of infection. For example, in the COVID-19, there are so many different rapid diagnostic test kits that are available in the market, and people are confused, and even the healthcare facilities are confused, like which rapid diagnostic test kit to use, and all the commercials are coming around, and it's depends on like how what percentage of the true positives are also expressed as a positive by the rapid diagnostic kits. You have to see the agreement. You have to estimate the sensitivity and specificity of those kits as well. And you have to check on WHO or OIE guidelines for the use of RDT in so many different zoonotic diseases. And I have told you about this. When you are comparing the RDT and RPCR or RT-PCR, you have to see the sensitivity and specific agreement. For example, sometimes the RDT sensitivity is so low that even if you toss a coin, that is 50% chance that you tell you that is correct. So many times tossing a coin would be better than the RDT. An alternative workflow for molecular detection of SARS coronavirus 2. This time in the COVID-19 pandemic, you have to test a lot of different samples. You have to test the samples from different places, and there's a lot of samples that is being generated in the hospitals and been sent to the testing centers. So you have to manage the workflow. You have to manage the how do you test the samples, and how do you collect the samples? So you have to test. You have to do all those thinking, and you have to strategically move in your settings. How do you so many different samples in a limited amount of time, taking the sensitivity of people and the pain that they are experiencing when they don't know if they're positive or negative. And so I'm trying to show you here there are different studies that have been published in preprints or already published in some journals. So time to complete the test. And so you can see there are on the bottom you see the time, that hours, and on your right in the column then you can see that there's RT-PCR or different tests that I'll be showing on later on. So most of the RT-PCR tests right now are taking 3+ hours to give you the result. And then there are like RT-LAMP, that is loop mediated isothermal amplification assay, which can be real time as well. And so the RT-LAMP or other different methods like recombinase polymerase amplification, recombinase added amplification, RAMP, that is rapid amplification test, and so on. Those takes around 1.5 hours to tell you the results. And then there's a digital PCR, which takes around more or less close to 2 hours to tell you the results. And then if you try to do the sequencing to identify the strain of the virus or any pathogen, it takes you takes more than or up to 4 hours. And in the time of COVID-19, they are taking samples from nose, that is nasopharyngeal patient swab, and it's been transported in a VTM. And it's being lied, or the virus is being inactivated in the laboratory. Some people like to do the direct test addition without going further in RNA extraction. And when they are going in RNA extraction, they use column-based or bead-based, like magnetic beads are being used. and purify the RNA, and then amplify the RNA and detect using the RT-PCR genes. But there are limitations of RT-PCR, and you know it very well by this time that all negative result does not exclude the possibility of COVID-19 infection, because it depends on like when the sample was collected, from where the sample was collected, if the sample was collected properly or not. And the false negative results may occur by mutation in the prime or probe target regions in the SARS-CoV-2 genome. So it could be false negative result, but you are positive already. And optimum timing of the peak viral load during infection caused by SARS-CoV remain to be fully determined, because you don't know when the sample was taken. If you are giving the samples, or if you are taking the sample from somebody else, you don't know when the infection started and when the person is on high titer of the virus. So you don't know the peak, and if it's not peak yet, and sometimes there's a limitation that the titer of the virus does not cross the threshold, and you won't be able to detect the virus although you are infected. And current RT-PCR is only 75%. So the results of RT-PCR you have to interpret very cautiously, and it's detecting the RNA or DNA, but it's not telling you the person is infected or not. The person is infectious or not. Sorry. Another limitation could be expensive equipment, and it requires a lot of trained manpower. It requires sophisticated laboratory settings, and there could be an error in the methodological procedures, like specimen collection sites. When you are transporting the sample from distant places, and you are not maintaining a cold chain or good transport media, then your RNA is not going to be stabilized. And within the RNA extraction itself, there are so many different nitty-gritty details that you have to be very careful, and you have to decontaminate the surface before you start the RNA extraction, and you're using the proper controls to be able to be able to determine if the person is infected or not, or to be able to determine your sample is correctly telling you the answer or not. And there's worldwide shortage of reagents and kits, and that is the limitation it's posing in different countries which are not manufacturing the kits or anything like that is involved in these procedures. So this is the time that there needs to be that we have to find an alternative for screening the people, so that you are not flowing everyone to the hospitals, and the chaos is being presented in the hospital. The RT-PCR is the one that, like in real time, you are checking the results in a real time basis. And there are other methods that are available for COVID-19 testing. That is direct PCR. I'll be talking that later on. It saves RNA extraction kit and time, and minimizes the error. The threshold values, CT values may be slightly lower than in extracted samples, but that's fine. You are minimizing the time, and you are also minimizing the error. So what you can do is pooling the samples as well. Like, this is not a technique, but this is not a diagnostic platform, but this is a technique that you can optimize your laboratory resources. It saves reagents. Best method for community screening. If you're a large number of people, you don't want to go in every household and test everyone in the household, but you can pool the samples from one household and test the samples. Then you will be able to tell if the household is positive or negative. If it is negative, it will save you, depending on the household size. For example, the household size is 5, then you are not going to test anyone. But if the pool is telling you the positive, then then you use different methods, like dividing the 5 group in a two, like 3 and 2, and then you are testing your subsamples. That way you can save the resources as well. And thermal amplification, I already told you about the lamp. And another one is lateral flow immunochromatography, which is basically an RDT, like paper-based. Also, it is very or too early to tell you the quality of the lateral flow immunochromatography that is flowing in the market right now. It's quick and easy and simple, but the relevance of it is really questionable at this time. And sequence, it's not in clinical use, but it will help you identify the strain and can be strategically used in healthcare facilities. And it's not. It's going to be expensive if people have to pay this one. So I'm going to tell you about this one, which I really like, the efficacy of a direct PCR that does not involve the extraction method. So you can see the amplification plot, and it's comparing without RNA extraction and with RNA extraction. That is the Kaizen amplification viral RNA mini kit that's been used, and in which you do extraction. It's a column based. And the line in the blue, you can see it's coming as the very nice threshold is 0.06 reactions, and the city value is coming around above like 40, close to 40. And then, which is the CDC cutoff, like 40 city value. And you are seeing different copies number of RNA being detected. And the one in the purple and the pink, you can see really nice looking curve. And it's telling you and it has a same copy number, same city value. So, but the copy number could be different. And it's telling you that it can be used in a settings where you don't have the extraction kits, and you won't get extraction kit if you are not producing the extraction kit in your country, because there is shortage of extraction kits right now everywhere. And the SARS-CoV-2 can be detected from COVID-19 patient nasopharyngeal swabs by real-time qPCR without an extraction step. And then either you do heat for the pre-treatment of the swabs or not. It actually improves the heating at 95 degrees Celsius, improves the CT values. And lower volume is more sensitive, lower volume of the sample swab diluent. Like, if you have 1 microliter here in the table, you are detecting the virus, viral nucleic acid, in a pretty good manner here. And so you have there's a reference. You can always go back and look and read the papers. But this chart is telling you the distribution of CT values from COVID-19 patient nasopharyngeal swabs following the direct RT qPCR versus the standard qPCR that includes RNA extraction. So it's telling you that the preheating nasopharyngeal swab samples prior to direct RT-PCR enhance the assay sensitivity. And here on your right, you can see the box plots where different companies extraction or the reagent are being used, like Magna Pure or Kaizen Cube, direct PCR. And then there's the PBS diluted at different time points and different temperatures. So what you can see is direct PCR is no different than the ones that are being used commonly in countries like RT-PCRs. So the extraction of the RNA prior to the RT-PCR did not enhance the SARS-CoV-2 poison sample. So I think I would recommend on doing the direct PCR in different settings that says the extraction states and extraction reagents. Again, here there is 2 panels, like A and B. On the first panel, which is 2019 nCoV assay kit developed by Thermo Fisher Scientific, and which identifies an ORF1a gene. And you can see there's no difference. The samples obtained by the same person, like the ones in the red or blue, those are P1 and P2. The P1 RNA and P1 NSS, that is the same. It's coming in the same. It starts increasing the same wavelength, but although they have a different reaction nature, but they are coming in the same kind of value for both being developed by the Thermo Fisher or by integrated DNA technology IDTs. And a direct PCR can be used to avoid RNA extraction process that I would like to emphasize. Another technique that you can do to avoid waste of resources is that pooling, which I already told you about. Like, when you have like here in the chart, you can see on the left, there are 8 people, and likely there is one people is infected there, and then that comes as a positive. When that comes as a positive, you divide that into 2, like 4 and 4. So the 4 that is negative comes as negative, and the 4 in which there's only one positive, then you divide that into 2 and test that in like individual. So this is the strategy being developed to test for the asymptomatic people, but you have to be very cautious in doing this technique in a place where there's low prevalence of infection. So I have here when the prevalence percentage is higher, when the prevalence percent higher, then you are decreasing the pool size, like from 11 to 3, and that also reduces the number of expected tests. Like if the prevalence is higher, then your pool size is lower, your reduction in the expected number of tests is also lower. So you are good when the prevalence of infection is lower and your optimal pool size gets higher, and you are reducing 80% of the tests, and that increases the efficiency in testing to 400%. And here is the one like pool technique builder that you can go ahead and play with it and try to find your optimum pool size when given, if you know the prevalence of infection there. Again, I would like to emphasize again the direct PCR and the pool testing up to 32 samples would be a good combination to go ahead. Again, these are some of the reading that you can go ahead and read. I'm not going to detail of this paper, but what I'm trying to show you here is single test CT value and pool test CT value. Although there's no significant difference between both in either E gene or S gene, but here in panel C and D, it increased. You'll see the pool test CT value is lower than the single test CT values at the same pool size. But so when I read the paper, I could see that lower CT values of pools than of single samples were because of the carrier effect of the higher RNA content in the pools. So with that, I'd like to thank you for listening to me, and I'll be happy to answer your questions. And I hope you are staying safe and healthy and breaking the transmission of coronavirus.
Thank you, Dr. Corner, for such an informative session. So we'll now move to question and answer session. So Dr. Sarita Negi has asked, will using RNA later solution affect quality of RNA extracted from COVID-19 positive sample?
Let me see that question.
It's in the chat box, sir.
Okay. I'm very new to this WebEx thing. Okay.
It's in.
What do you?
I will recite you, sir. Sure.
Okay.
So Dr. Sarita Negi has asked, will using RNA lateral solution affect quality of RNA extracted from COVID-19 positive sample?
That's a very good question. RNA later, RNA later obviously protects the virus, but I would be very careful in using RNA later. Not many people are using RNA later to stabilize the RNA for COVID-19. but I don't think there will be much difference. But I haven't seen any of the results coming out using the RNA later.
Thank you for the answer, sir. Madhavi Lakshminarayan has asked, though our BPT test is help in diagnosis of brucella disease, what will you prefer as diagnosis tool for this disease, as RBPT cannot be taken as confirmatory test due to various environmental factors?
So the question is, can you recite the question again?
Sure, sir. So, though RBPT test is help in diagnosis of brucella disease, what will you prefer as diagnosis tool for this disease, as RBPT cannot be taken as confirmatory test due to various environmental factors?
Yeah, I think I would not depend on any of the RABID diagnostic test is based on the antibody right now. It's not telling you the right answer, like you are infected or not. When you are trying to break the transmission cycle, it doesn't actually help. It only tells you the exposure. I would use the RT-PCR as a method of diagnostics, not any of those rapid test kits.
Okay, thank you, sir. Diva Dingra has asked, can we go for strategies like sampling of sewage for detection of infectious organisms on a large scale, as these organisms appear days before the appearance of clinical symptoms? Will it not be a better way to prevent a pandemic-like situation?
That's again a very good question. What you are detecting in the sewage, you can go back and tell that the community is infected or exposed. The virus is circulating in the community, but you have to be very careful in interpreting that result, because when you are finding the RNA in the sewage, you have to again compare the sewage sample to be able to tell that whether the virus is able to infect or do a new infection to somebody in the community who may be handling the sewage, or like the waste handler people. But it tells you the burden. It obviously tells you the burden of the community, and it can help you to strategically manage the lockdown or the exit strategies. But you have to on your Excel sheet, you have to put both, how many new cases are coming in the community at the time when you are detecting the RNA of the virus in the sewage. So that way you can tell whether or not both are going to give you a complementary result in trying to manage the pandemic.
Okay, thank you, sir. We'll now take few more questions. Batch B has asked from YouTube, is there a standard sensitivity and specificity that RDT has to pass to be considered effective?
Well, I obviously like to see more than 90%, obviously close to 100% or 100%, because it's dealing with the human lives. So anything below 50% is too bad. Above 50%, we have to be very careful. Again, something below 90% would not be that good in this time.
So we'll take two more questions. So Akhtar Rasul has asked, sir, could you please explain nicking enzyme amplification reaction in diagnosis of viral disease?
Sorry, say it again.
Could you please explain nicking enzyme amplification reaction in diagnosis of viral disease?
Nicking, I didn't quite understand the question.
Nicking enzyme amplification reaction.
Nicking, I'm sorry, I don't know. So I couldn't be able to answer that question.
Okay, sure, sir. Yeah. So this will be our last question. So Bau Arwan has asked, Has the animal processing product detected with sequencing gene? Example, ice cream, beef stick, and etc. What tool improve use? So it's like confusing. So he's trying to ask, has the animal processing product detected with sequencing gene? So has animal processing product is detected with, so I still can't understand this question.
No. So, but what I understood from Ahmad is, has the animal processing product detected with sequencing gene? Well, if you are trying to sequence the gene, you have to use the sequencer, and that is the tool that you will use from either it is from animal processing centers or from different centers. So I think that is what I understood.
This is all for question and answer session. So I hope all the participants have enjoyed this very informative session by Dr. Corner. So the presentation was truly amazing, and I hope all the participants has learned something new from today's session. So we are very grateful to sir, the organization team, and from me personally, I would like to extend a very thank you for you to joining us in this session. The code for today's session is YZ68VL. So I repeat, the code for today's session is YZ68VL. So that's all from my side as the presenter, as a moderator. So Anas, are you there?
Yeah, sure. I'm here.
Yeah, so the time is yours. Yeah, thank you.
So guys, we are ending this session for today's session. So sorry for all the inconvenience which have happened today. So stay safe and tomorrow, especially attend the session tomorrow. We have 2 more session tomorrow, so please attend the session. Thank you so much, and sorry for all the inconvenience. Thank you all. Stay safe. Bye.